Today is Wednesday.
You have a meeting? Because I was
Today's
gonna say.
Monday. Huh?
You have a meeting?
I do have way too many. Friday, we're gonna do our next Play-Doh project, so I'll bring some extra Play-Doh. We do have some back here, but bring some extra if you have it, and we're gonna do our next wild competition, of which the difficulty level is gonna increase substantially, so. Y'all got too good at it, so I gotta raise the bar a little bit. Of course, healthy competition, 4 points. All right, so what are we looking at here, guys? Y'all did this in lab, at least half of y'all yesterday. What is this?
That's a lateral sternum.
Is it lateral sternum? What is ideal for a lateral sternum when it comes to SID? What must we do?
72.
We must do 72 inches, and did they explain to you why that is yesterday?
Magnification of the sternum.
Because of magnification, because whenever we are in a lateral against the bucky, what's gonna be present? A lot of what?
Tissue. These breasts.
Yes, but that varies, but OID. OID was the word I was looking for.
Oh, yeah.
OID.
That
Yes.
thing.
But yes, that's actually, what you brought up is not incorrect, because that's a part of puffing the chest out as well and trying to move that sternum out of that tissue to give us a better look at it, yes. But yeah, 72 inches, very, very, very critical. What did y'all learn about the REO when it comes to SID?
40.
Y'all learned 40, but what else? What's the
30.
optimal SID, even though it's weird?
30?
30, correct.
Wait,
30.
what?
So that is
REO
one of the
sternum.
only positions in X-ray which is now calling for a 30-inch SID. In fact, I've never done a 30-inch SID in my entire career.
Yeah,
It's
it
brand new
was
to me.
really close.
But that's a new change in the newest edition of your books, of what they're calling the optimized way of doing that REO exam. So do make note of that. Even though you're gonna see most people always doing 40, 30 inches is now that optimal SID to maximize the quality of that image. By the way, when it comes to doing an oblique sternum, what's the other way we can do an oblique besides an REO?
LPO?
We can do an LPO. Do we ever do an LEO?
No.
Why?
The
Don't you want to
heart.
look at your left sternum?
The heart shadow.
Very good, very good. Y'all are correct. We never do an LEO, period, no matter what, because of the shadow of the heart. I'm getting ahead of myself on positioning, but that's all very important things to remember. It's a really good test questions. But back to this lateral sternum. Let's see what we can remember from the anatomy that we reviewed on Friday. Let's start at the very top. And what part of the sternum is that top arrow pointing at? The manubrium, mediastinum. We're going way back. That's
That's not the whole story.
good guess. That's back first semester.
It's all right, right?
That's all right.
She knows it, so she knows it.
It was a 3-day weekend. We don't judge. It's okay. Now, mediastinum is the area of the heart, aorta, esophagus, trachea, and the lower chest. But manubrium, correct.
He was close.
Manubrium. What is the second arrow pointing at?
The sternal angle.
Sternal angle, or what else is it called? It has a joint name. Manubriosternal joint. Manubriosternal joint, correct. All right, what about this area right here? The body yadi? Correct. And what's that little point there called? Xiphoid process. Very good. Very good. Would you say this is a pretty optimal lateral sternum? We haven't gone over evaluation criteria yet, but what do you think?
Yes.
I think we could have collimated a little tighter personally, but overall it's all there. It's pretty good. You can see it quite well, yes? I would say they could puff that chest a little more. It looks a little relaxed to me, but because you see how here's the danger. See how that sternum is on top of that lung tissue right there? That's what we want to avoid, and we want to puff that chest out and get it right in between the breast tissue and the lung tissue there. Very, very good balance of the bow, so you can maximize the view of that sternum. How about that pretty thing there? Look at that pretty thing. They never look that pretty. They never look that pretty. I wish they looked that pretty. But that's a very nicely radiographed sternum using a very nice breathing technique. But what can we label? A is a tricky one. Does anybody know what A is? Look very closely. Look very closely.
Is that the clavicle?
It is a clavicle, correct. That is the clavicle. That's the sternal end of the clavicle. See that round edge right there? That's the clavicle fitting into that SC joint you see right here. Y'all see that? What about B? The jugular notch. The best palpation point because it makes your patient go, ugh, when you, no one's done that? Good, y'all don't palpate as hard as I do. I'm told I have very sharp fingers when I palpate, so.
You know who does? Mr. Fox.
Yeah.
You haven't seen mine yet. Mine are like blades. That's what I'm told at least. Anyway, back to it. What was I talking about? Yeah, C. What is C? That is going to be synonymous with what we see right here.
SCG.
That is the area of the SC joint right there. Letter C. That's the SC joint. Can't see the clavicle on that side like we see right here, but that's still a little notch. You see it? Does everybody see that? Yes?
Yes.
Okay, making sure. What about letter D? What was that? Look very closely. Chromium. Well, I hope not. We're not that far from each other.
First rib.
What'd you say?
We had a first rib.
Well, take the head off.
The
Okay, rib.
first rib.
Just say first rib.
Oh,
There you go.
first
The head is on
First,
the
that's the
backside,
first
right?
rib, guys. That's the first rib right there. Curve. Remember that sharp curve? You can't really see the whole C shape, but that's where it's connecting right there. What about letter E? Manubrium, letter F. Sternal angle or manubriosternal joint. Letter G.
Body.
And what about letter H? Xiphoid process. What about these little grooves? They're quite groovy. Facets. Those are the facets. And what fits into each of those facets? The cartilage from the what? From the ribs. So this is a rare case where we can actually make out that cartilage quite clear there. This cartilage has probably started to calcify on this image, which is the only reason we can really make that out so clearly right there, because otherwise that would start becoming invisible at about that point where that rib's attaching. By the way, what position is this? REO. So guys, keep in mind, Monsi had mentioned an LPO being an alternative, which it is. You want to put this in your notes. We only ever do an LPO if it's a trauma situation and they cannot get in the REO. Otherwise, REO is the optimized position every time, no matter what, on a sternum. So if you're looking at an image and it's not labeled, you're always going to assume that to be an REO every single time. REO is optimal. LPO would be the trauma version. Like if they're on a backboard, you have to get a sternum. How many degrees is that oblique, by the way, guys?
15.
15, very slight, very, very slight oblique. All right, there's two more. Not as pretty. This is a little bit more what they're gonna look like right here. Can you even see the sternum? Anybody make it out? Look very closely.
You can see the facets.
You can see the what?
The facets.
The facets? Can you see it? Look very closely.
Very, very light.
Yeah, it's
very, very, very light. Right
Very
here.
see.
Right here, guys. See it right here?
Yep.
I always
Very,
look at
very
the
light.
clavicle.
See the little facets?
See,
It's almost invisible. Almost invisible there. But this is what they'll most likely look like on most of your x-rays. They're not as pretty as you see on these, unfortunately. What is this? This is a nice PA ribs. PA ribs. So what would be the main thing I want you to focus on these? Of course, everything that we know from before, but remember what I said, we need to focus on counting the ribs. Can you find the first rib?
Yes.
It's the C. Y'all see the C? Do you see the? Do you see the C? Do you see the C? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Can you place them in the second rib?
Second rib is right here. See it? There's the first sharp curve, and there's the second one right under it. Be careful, because a lot of people tend to mistake that clavicle for a rib. That's not a rib, that's a clavicle. And once again, what can you do if you're having a lot of trouble seeing that first one? Work backwards, 12 to 1. That can help you out a lot. What are the areas in between the ribs called? Intercostal spaces. So if I was to point, how mean do I want to be? Let's see. We'll make y'all count. What space is this? Very good. That's the 6th intercostal space. Very good. Where do we start counting?
Between the first and second.
In the first and second right here. Correct. Very good. And how many do we have total? 11 spaces, but how many ribs? 12 ribs. Excellent, excellent, good. When we look at the ribs and where they attach, where do the ribs attach specifically?
The cartilage.
On the posterior aspect, I'm sorry.
To the vertebrae.
To each corresponding numbered vertebrae, but where are the two spots they attach at?
Oh,
Start with the rib. What two parts of the rib attach to the T vertebrae?
The thoracic.
The head and the tubercle, talking about the rib.
Okay.
The head attaches to the what?
The vertebral bone.
Costovertebral joint, which is on the body of the vertebrae. And the other joint, which is where the tubercle attaches to the what? TT. Transverse process of the vertebrae via what joint? Transverse joint. Costovertebral joint, costotransverse joint. Those are both what types of joints? Synovial, correct. Good, very good. Excellent. But let's not forget our other stuff. You know, what's this called?
The coracoid.
Ooh, chromium. Coracoid. Okay, that's why we're reviewing here. What's that edge called?
Oh,
On the scapula.
The lateral border of the scapula.
Lateral border. What about this border here?
The medial.
This point here?
The inferior temple.
What about this little joint
The
here?
glenohumeral.
I said joint.
Oh, okay, so that would be the
I was gonna
landmark.
get you on that one.
Okay.
Scapulohumeral joint, but the landmark is the
Glenoid cavity.
glenoid cavity. Very good. Very good.
Where's like costal groove? Can you see it?
Costal groove, cannot see that. No, so you're only gonna see that on a diagram. You're not gonna see that on an x-ray. Yes. What about, let's just, for fun, what are these spaces called? Because we're gonna be doing that in the next chapter.
This.
No. I just wanna see if anybody knew it.
What is all this?
Starts with an I.
That's what it said.
What Cody said. Did you say that?
I said intervertebral.
I didn't hear you. I'm sorry. I got really bad hearing. Intervertebral disc space. Intervertebral disc space. I apologize. I can't hear. All right, let's move on
I
here.
have a question.
Yeah.
So the head of the rib is what attaches
To the body of the vertebrae posteriorly. Yes.
So then when it comes
They're both
forward, that's
posterior.
When it comes forward, it's
that's
gonna.
where it attaches to the cartilage.
Sternum.
Correct. By the way, what's the name for the attachment point of the rib to the cartilage anteriorly?
The costochondral.
Costochondral union joint articulation. All three of those names. Costochondral joint union or articulation.
There's 10 of those.
There's correct. There's 10 of those because the floating ribs do not have them. By the way, what are our true ribs? What are our false ribs?
8 through 12.
12, and what are our floating ribs?
11 to 12.
Very good. Very good.
Wait, why are they called false ribs again?
Why are they called false ribs? Because they have because when they come together at the cartilage, they have a singular attachment.
Okay, that's
Whereas the true ribs each have their own individual.
okay.
Yes. Good, good. Y'all remember this quite well. Very good so far. I thought y'all had forgotten it all over MLK holiday. Very nice. Okay, this is another ribs x-ray, guys. It looks pretty synonymous with a chest x-ray, right? And it's going to. They're going to look almost identical. There's a very close look at some ribs there, guys. Does anybody know what we're looking at here specifically? It looks kind of weird, doesn't it? This is a PD, correct. How do you know it's a PD? Well, these are actually the T vertebrae here, and they're not fused together at all. It's all cartilage there. So what are we looking at specifically here? PD as a child. What do y'all think we're looking at specifically here? This is a baby, by the way. It's a very small baby. Y'all know what this is? What these pathologies are?
They're healings.
Correct. They're fractures, but they're healing fractures. So when it comes to ribs, what you're going to do probably the most on children is allow rib x-rays if there's ever any suspicion of mistreatment or abuse on a child, because the most common abuse manifests with rib fractures because of what very bad people do to these kids. But you'll look specifically for these healing fractures. And something you want to develop an eye for if you ever deal with children is you want to develop an eye for these. Even though the radiologist is going to see it too, you want to document stuff like this. This is indicative of a past injury that was never treated properly. It makes that little ball shape, and that's what we call a healing fracture. It means that child was abused in the past. Happens quite often, more often than you can imagine.
It's all calcifications.
It's just the way it's just healing bad. It's ossification. It's healing.
What do you see a lot of these?
Oh yes, almost daily. Almost daily.
How
There's a
did
few
you
more
like-
examples right there. 2 more pediatric rib x-rays. You're gonna do a ton of these. This one right here was looking for a foreign body, which you see right here. That's a foreign body. But this is another example of those healing fractures. Can you see them?
Mm-hmm.
You'll develop an eye for these. You always want to document that. Do you see more healing fractures that aren't labeled with an arrow? I see a bunch of them.
Yes.
Yeah.
Towards the front side.
You'll see them
Yes.
right here.
Mm-hmm.
So this child was abused quite a bit because both sides are fractured and they're old injuries. And you can usually tell how old, like how far back those injuries were. These are probably almost a year of healing. We
I
were-
don't have
But
a
they've
broken
got
face,
some
I
other
can't do
fractures
it.
on that side too. Right in front of
I
the
don't
healing
have a
spot.
broken face. I see
What's
that,
that?
I would
They've
be
got
so
other
pissed.
fractures right in front of the healing
I
sites.
couldn't do the kids.
See on this right here? That is actually supposed to be there. That's the rib still fusing. Good eye on that. It does look like fractures though. Yeah. But yeah, that's usually from people either throwing a child or squeezing it. That's how that usually occurs. Just to give you some context on that. People, especially also the shaken baby syndrome, when they do the shaken baby syndrome, not only does that hurt the neck and the head, they usually squeeze the rib cage really hard. And children, of course, their bones are very fragile, very, very fragile. So you see this more often than you would believe, but it's usually quite sad. Okay, this is an example of 2 of our SC joint x-rays. These actually come in to Harris Health a lot more often than other facilities. This is a great comp to grab. They come into the bone clinic quite a bit. This would be our oblique, this would be our PA. So you guys did the oblique yesterday, and I'll show you a little technique on that as well. That kind of, I don't know if they showed you, there's a way to situate the body that naturally puts you into that slight oblique on the table. We'll demonstrate that in class as well when we get to positioning. But this would be our REO that we're looking at right here, and that would be our PA. The oblique will be a unilateral exam because we're opening up one of the SC joints, whereas the PA will be a bilateral exam because we're looking at both. Well, that's a good thing to write down. I don't know why I'm not writing that down.
Wait, say it again.
Sorry, I only saying that once. That's a gold star question.
I got $3.
I just, you know what, I was paying attention.
I
Your cup is smaller.
told you I'm cutting back. I am cutting back.
Which is
Um,
like,
The obliques of the SC joints will focus unilaterally on one SC joint, so we're opening up one, whereas the PA is going to be a bilateral exam where we view both SC joints side by side.
We'll open one side, the oblique.
Correct, side down. But we'll get that. We'll hit that again in position. I'm jumping ahead of myself. But also we can see parts of the sternum. Y'all see the sternum as well. Manubrium body. There's the jugular notch. There's the 2 SC joints. Let me go back a second. Does anybody know what specific oblique this is right here, based on what we're visualizing? We haven't gone over this yet, but I just want y'all to think critically for a second. On the right side, what specific oblique is that?
LPO.
That is an LPO, correct. How do I know? You're gonna put a marker first of all on the side you're elongating. That's a key factor, first of all. Our posterior obliques will elongate the side down. So we're labeling the left side, it's elongated, it has to be LPO. Whereas the PA obliques, where we're facing the table or the bucky, that's gonna elongate the side up. So if I look over here, this is also an RPO, we're elongating the side down. If that doesn't make sense, we're gonna hit that when we go to positioning as well. We'll show you how you can tell which oblique it is based on what's elongated and which marker we're using. It's gonna be a key factor in helping you determine what oblique you're looking at. Good job, I just wanted to see if y'all knew what that was. We'll come back to that. All right, a little more info here, guys. So, when we're talking about respiratory movement, of course, our rib cage is extraordinarily flexible to accommodate the air coming in and the air pushing out via the diaphragm pushing that air out. The obliquity of those ribs will actually decrease with what we call a deep inspiration, and the that's a hard word to say, obliquity will increase for the deep expiration. So as I breathe in, the oblique's gonna lessen with my ribs, their shape, the general shape. When I blow out, that obliquity is gonna get larger, it's gonna increase. So it's a little bit inverse to what you would naturally think. It's an inverse relationship there. Oblique of ribs decrease with deep inspiration, they increase with deep expiration. Now our ribs, two very key points, and man, I had some seniors miss this question right here, guys. I had this on their practice test exam, bullet point number 3. I think 90% of the class missed this right here. First, bullet point number 2. If we're looking at the ribs above diaphragm, we're always going to view those best through air-filled lungs. Therefore, we are going to perform it almost just like a chest x-ray. It basically is a chest x-ray. So we're going to go with those breathing instructions, that big deep breath, blow it out, big deep breath, and hold it. We want to see those ribs against the air-filled lungs. That's the best way to see the upper ribs above the diaphragm. Below the diaphragm, we're going to examine those through the upper abdomen and add this to your notes via expiration. We're going to have the patient expire the air to best visualize those through the abdomen. Like I said, 90% of the seniors missed that question because all they did was they read the word ribs and they assumed, oh, I look at those through the lungs. They didn't read the whole question. It was asking below diaphragm, so they all missed it. Remember that trick I keep telling y'all, reading a question 3 times before you answer it? I'm telling you, if you can master that, you will get such better grades. Such better grades. They all told me they did not read the whole question. They just answered it quickly.
All of them missed
When
it?
do they?
90% of them missed it.
When do they take their test?
When do they take their HESI? That is going to be the week before TSRT in April.
At least y'all never take it before.
Oh. Oh, we didn't.
It is before. That's what I said.
Yeah, that's what I said, at least y'all let them take it
Oh, yeah,
before or
yeah.
after, so you don't come.
Are we gonna take an exam like that sometime this semester, or?
No. Y'all will start doing practice registry exams in the summer. Okay, so the diaphragm, when we're talking about how large it is, it's going to average approximately 1.5 inches between your deep inspiration and deep expiration, and that's going to be less in your hypersthenic patients and more in your hyposthenic patients. Do y'all remember what those are? What's a hypersthenic patient?
Me?
No, it is not. Hypersthenic is a morbidly obese person, whereas hyposthenic would be a little skinnier than your average. A little skinnier than your average person.
So let's see.
Bless you. I've always wondered, it's so funny we say the phrase bless you when people sneeze. You ever just want to say something really random out of context just to schmooze them?
Oh.
Like, be thou not blessed. Like,
That's just not right.
I tell my family, like after they sneeze a bunch of times in a row, and many blessings upon you. And usually it stops. It's like, what? Stop.
My brother's like, all right, that's enough.
there's like,
It's more polite than to say.
bruh, do you have to sneeze?
You'll tell me because like I
I'm
have.
not sending you any blessings. You have to sneeze.
Oh wait.
I do bless you though,
Can we go
Shane.
back?
I'm just picking. I'm just
Can we
picking.
go back?
Can I go back?
Give me 30 seconds.
Grief.
Is the sternum also called an thigh bone?
Is it
Okay,
what?
you're good.
The sternum also called a thigh bone?
Thigh bone? No, but it kind of looks like a tie, doesn't it? It's called a gladiolus, like a sword. Told y'all.
But I see more of a thigh.
It does look like a necktie. Yeah.
And I have ties right then.
That's a good point.
All right. So once again, guys, y'all already answered this, but which ribs are classified as our true ribs? A, 1 through 7, you are correct. The most inferior portion of the sternum is the what? The xiphoid. You got it. Not too bad so far, right? That's all the anatomy for this chapter. That's all the anatomy for this chapter. It's not too bad. We got a good slow start to this semester. Do not be deceived. It's going to get rough the following chapters, but we're starting slow with this chapter. Let's talk about a little bit of our rib pathologies. Here we go. All right, so yeah, cracked ribs, guys. It is not a good time. Has anyone ever had cracked ribs? I think I asked you all that. Anyone ever broken their ribs before?
Nope.
Shaheen did. It's right. You said you were out though, so you didn't feel it.
I wonder.
I've always heard it's a horrific thing having your ribs broken because every time you breathe, it's like you're suffocating on yourself because those ribs are like stabbing your lungs. As you can see, they do rub up against your lungs. Those cracked ribs. So it's good. You have to get those set really quickly because you can actually puncture a lung with a fractured rib. Yeah, it can cause a lot of damage. Most commonly, when we're talking adult patients, what do you think the most common rib fractures come from? Car accidents, correct. Usually airbags, actually, believe it or not. You know, airbags cause more fractures than a lot of the car accidents. They're there to protect you, but man, has anyone been hit by an airbag? Well, it punches you in the face or the chest, like it causes some damage. No one, only one that's been hit with an airbag?
Have you?
Yeah.
I did. I
Yeah,
did
it
it.
made my nose bleed, it like burns my face.
Yeah.
Really?
I didn't. It just knocked me out.
Yeah, it hits you with a big force, yeah.
So sometimes it's not good to have it happen.
No, it's good because it keeps you alive, but it's gonna cause some damage in the process.
Hit me here, so.
I know you want to take that chest fracture.
What's that? See what you did there. That's an example of some rib fractures, guys. Can y'all see the rib fractures very clearly?
Yeah.
Now, keep in mind with rib fractures, and this is why it's so important that we as techs try to give those quality images, because I'm sure y'all have seen by now, a lot of techs really stink at doing rib x-rays. They're not the best quality, especially those obliques. But why is it important? Because not all rib fractures are this easy to see. A lot of rib fractures are hairline fractures. They're very tiny, they're almost invisible. You need a keen eye to be able to see that. A very well-trained radiologist, and believe it or not, a lot of radiologists screw up on rib x-rays. They overlook a lot of fractures. It's easy to overlook. You know, and you can imagine as a radiologist, they work these like 80-hour weeks in a dark room, and imagine staring at a screen for 40 hours at a time, and you're gonna miss some stuff, which is kind of scary to think about, but that does happen. Rib fractures are the most notorious things that they miss. And that's why I said, if you ever see something special on a child, a healing fracture, document that. You never know how long that radiologist has been working, and they overlook stuff. You can be the one that actually is the main part of that diagnosis for that patient, and save that patient as well. How do they repair some of these rib fractures? Well, this would be some severe ones here. They're gonna put some plates in there to hold them into place. Sometimes they'll just put a brace around the patients. They'll naturally heal. It depends on the severity of the fractures and how out of place they are, of course. Shaheen, you didn't have to have any of that done, did you? Okay, good. Just another example of a few more rib fractures there. A little bit more subtle. We can clearly see this one here with that little shard sticking out, but can you make out the other ones? A little more difficult, right? And that's not the best quality image. Also, we got this giant artifact in here, that ugly thing, bringing the image quality down. Y'all, that's some poor spatial resolution. Did y'all talk about spatial resolution yet? That is some sorry spatial resolution, which means, what am I saying when I say it's bad spatial resolution? Not contrast, but what am I saying when I say it's poor spatial resolution? It's very noisy, pixelated, very noisy. How could they have mitigated this lack of spatial resolution? How could you fix this? We're gonna jump ahead to some QA/QC here. How would you fix that image? That's a very ugly image. What would you do? What are the mitigation factors for improving spatial resolution? Increase mass, that's a big one. What else can you do? Remove artifacts, thank you. That big metal bar there, that's actually absorbing a lot of the x-rays. This is a metal bar in the bed that they're laying on.
Agreed.
Unavoidable, but I'm glad you said that. That is a common mistake. A grid never improves image quality. This is not the class, but write that down. Don't forget that. That's a registry question. No. What is the main purpose of a grid? To reduce scatter. That is all it does. It never improves image quality. Never. Just reduces scatter. Very common mistake. But yes, remove the artifacts, increase the mass. There's one more big one we can do, guys. What else would reduce the noise in this image? A lot of people actually forget about.
Increases your spatial
I thought it did.
The magnification, the SID.
Increase SID. So increasing SID actually improves your spatial resolution as well. That's the one people forget about the most. 'Cause that's not the most likely scenario, the most likely thing you're going to do. But increasing your SID will improve the spatial resolution. Yes. All right, that is just a couple more pediatric x-rays there, guys. Like I said, you're always looking for these rib fractures for pediatrics, looking for those signs of abuse. Not as clear on the image on the left, but can y'all see them on the image on the right? If you can't, they're pointing right there. Those little round oval shapes, that's those healing fractures. There's some more right there. Now those are actually detached, Jay. Those are actually detached, as you can see. That's some severe, that's some fresh, that's what you call some fresh fractures right there. That just occurred before they brought them in.
So, how do you maneuver? The kid has to lift their arms, right?
Yes. They're gonna scream. Hopefully the nurse was nice enough to give them painkillers. That's,
I thought we weren't allowed to manipulate people who we suspect are.
well, how else are you gonna get your x-ray? You have to. You have to. When it comes to babies, since they're screaming already, as cruel as it sounds, you kind of just let them scream and get the x-ray done. You just do what you gotta do. That sounds really cruel, but that's a harsh reality of pediatrics on that. And you have to get the arms out of the way. If you don't get the arms out of the way, it's gonna obscure what you need to see. Janelle, you got a question? Oh, so that was an abuse case, very likely. Was there any history? We're gonna have a whole class on that, by the way, guys. We're gonna do a whole pediatrics chapter in Rad Pro 4. You'll learn how to recognize a lot of that stuff and what we do as techs to aid those children that are going through that kind of stuff.
Did they use digital markers? Yeah. Yeah.
Oh, big no-no. So there's a huge danger in that. So that's a great example of what you should not do, guys. So Janelle was part of a very likely abuse case with a pediatric yesterday where they did x-rays on a child that had visible bruising and they were doing rib x-rays. They put digital markers on that radiograph. Why is that a bad thing?
Because you can't use it anymore.
It will not be a legal document at that point. So if that child was going to be removed from custody and they want to use those x-rays as proof, they would throw those out. They would not be considered a legal document. Yeah, which is very unfortunate. Okay, let's just show you some more rib fractures, guys, some of the damage it can cause. Let me move on here. Flail chests. Does anybody know what flail chest is? Did y'all hit that in pathology? Flail chests. Well, there's your definition right there, guys. It's a specific type of rib fracture where that segment will actually seep into the chest with inspiration and expand out on expiration. So it's a floating fragment that's going to go in and out as you breathe.
Does
So
it
we
attach to the lung?
It's not. It's basically just floating there.
Just sitting.
It's going to go in and out. It's like a complete separated fragment. Yeah.
What's holding them from like sliding around?
Nothing. And it can slide around.
Oh my god.
Hopefully they've got to the hospital at that point and they've isolated that. Yeah. So that's what we call flail chests. So Ryan,
Yes, sir.
sorry. Coffee's kicking in now. Yeah.
Hey, you want more, huh?
No, I don't. No, I'm resisting. I'm doing good. You should be proud of me.
I am.
You're doing well.
Hmm?
You're doing well.
I know.
People don't want to talk about like coffee and sugar, but there's one of
I'm
those.
not even using sugar and stevia.
Oh.
I have eliminated all my sugar intake this month so far, so
New Year, New You.
that's right.
Did you change the type of coffee as well?
I usually change it every month. Depends on
Have you
what I
ever
see.
tried Cuban coffee?
Yeah, it's pretty good.
They said that you can only have like a little cup because
coffee is very unique, really good Turkish coffee. You ever had Turkish coffee?
Yes.
No,
That
no.
is amazing.
You should bring that. I'll try it.
I'll try to do that. It's really good. It is really good. Okay, sternum fractures. So another very dangerous fracture, guys, because the shape of that bone, it's called a gladiolus for a reason. It's like a blade almost. So when we get these sternum fractures, they can resemble sharp blades. Now this is a very subtle fracture. You can't really see it unless you look really close. It's right there at that connection point, that sternal notch. It's a very slight fracture. By the way, this is like very trashy. This tech should be ashamed of himself taking this x-ray and turning that in.
What is that?
That's a whole lateral chest.
Yeah.
What the heck are they doing? Look at how poor that spatial resolution is. Do not bring me a comp that looks like this. You can bring that to Bonilla and Fong. They'll probably tell you the same thing as me. Don't bring that to me.
Well,
That's
that would
bad
be a
idea.
great one for the project, like the before and after, which
Oh, you
one's
mean
not.
the unacceptable?
Yeah.
That'd be a great unacceptable. Yes.
But sometimes they say open it up because they want to make sure there's nothing,
Yeah.
like they don't want to catch
So
everything.
I'm gonna tell you. I'm gonna tell you a little secret here, Reagan. When they tell you that, they're extremely unconfident in their abilities. There's never a reason to open it up to include more stuff. That's a tech that's very is lacking in confidence and not sure what they're doing.
Yeah, they open it and then they just crop it to where I already.
Yeah.
That's a poor quality practice.
And then the tech is looking at
When
you
you
like
become
that when
techs,
you're
you are not going to do that, or the ghost of Donahue Pass is going to haunt your dreams. You were not going to do that.
Well,
Like,
she was like had a gangrene finger thing, and she told me to open it all the way to like the wrist because just in case, like it was, I don't know. She didn't give me a good explanation actually. Yeah.
Because
She said that.
I'll stop. I'm gonna get too mean here if I keep talking. But you get what I was saying. That's a poor excuse for lack of confidence.
Or there's techs that look at you like this.
Is what?
Oh, when you call them maybe?
This
Like when you
this
wanna
is
call it,
a.
Or they'll come over and just
I wanna say it's a
whip it back
type of
open.
port.
Yeah.
Open it back
Well, it'll be
up.
like perfect.
I believe it's a type of a port, if I'm not mistaken, where they inject medication or tubes into.
Yeah, they're so yummy.
Not necessarily. They come in all
Tell me
kinds of
if-
shapes and sizes. I might be wrong, but I think it's a port. It looks like a port to me.
What if they shot a lateral test and found out there's a fracture?
And they probably order a separate one, very likely. Now this is a more severe fracture. See how that one's separated? And look, the shards are superimposing each other. This sharp part here, this sharp part here. So those can actually break the skin as well, come out of your chest. Yeah, very severe fracture. That'd just be a sternum fracture. Yep,
And you still gotta make them do the Superman pose.
as best you can.
Oh.
Yes. If they do that Superman, they'll start poking out more. And
Oh.
Hold it right there. Hold it right there. Don't move. See the bone poking out.
Hold your breath.
Now you can really nail that lateral in. You can see the bone coming out. Man, you have no excuses for not getting a true lateral. I'm just saying.
Yeah, if you come in with the lateral chest,
You're
Oh, bad fracture, but man, that sternal notch though, you can really make it out. That's just showing you another view there, guys. See how it looks like actual blades with sternum fractures. They can be very painful, as you can imagine, and very dangerous.
What is wrong with this picture?
What's wrong with it?
Why does it look like that?
Poor quality.
Okay.
Okay, pectus carinatum. This is what we call pigeon breast. Pigeon breast, it's a genetic disorder that we'll see in a lot of our adolescent teens when they come into, I see this all the time. It'll actually make it makes the chest jut out, and this is happening because of an unusual birth defect. It's a growth of the rib and the breastbone or sternum cartilage. It's a major birth defect. So they'll actually put a specialized brace on the patient to try to reduce that. It takes many years, but they can actually reduce it quite a bit and return that to a normal shape for that teen or child. Pectus carinatum, also called pigeon breast, called as such because it's kind of shaped like a pigeon's breast.
I don't know what a pigeon breast is.
They have like a big chest, kind of pokes out. You ever seen a
Yeah.
pigeon?
Yeah, I have, but I don't pay attention to the shape of its chest.
I think it looks like kind of like a loop.
It's kind of like just a protrusion. They They got like a big puffy chest.
Okay.
Don't ever like that.
He pointed the practice kind.
Say that again?
He's pointed practice kind.
Right here. See how it's
In the,
jutting out?
Is that bad?
It's not the, there's actually one that's gonna be like a dent. We're gonna get to that one next. This one's more of a protrusion.
Okay.
This is the angle you're looking at that right there. Kind of looks more like a dent there, but it's actually protruding.
Okay.
What does the bracelet they have to wear look like?
I think I have a picture of it. Let's see. Yeah, there you go.
I used to go to
Oh.
school
There.
with this kid that wore that.
So you can really see it there, guys. Can you see the difference now?
Yeah.
So they'll wear these specialized braces and they'll help that grow back into place properly. And what's the other one? What we call the pectus excavatum. Pectus excavatum, which is also called funnel chest. That's also a congenital deformity of the chest wall. And that's going to cause the ribs and breastbone to grow in an inward direction, almost like it's collapsing inward, making an actual dent or a hole, which you can really see right here, guys, in that picture. Cody, which one did you have? This one right here. Was yours severe or was it more?
It was like right in the middle. It was enough to where when I had surgery, the insurance covered it. Because they measure it like, I guess like that. And depending on how deep it is, they'll decide. Because I didn't have, it was compressing on my heart.
Right.
I had a bunch of tests in it.
Which that's the big danger right there. If it's extremely severe, it can actually compress on the heart, like Cody was saying, and cause danger to that patient. Because it'll keep going inward. It'll keep growing inward. It won't stop. As you can imagine, it'll start compressing the organs, compressing the heart, the lungs, causing danger to the patient.
Where's the sternum on that?
Where's the sternum? It's very hard to see, but about right here.
I thought it would be more inward.
I mean, it is.
No.
Next picture, y'all still running? Are we good?
Okay.
Here's an example of a severe case. And as you can see, that's just gonna keep going inward, and you can imagine how that would start compressing the organs in the chest, causing a lot of danger, and, you know, hard to breathe, your heart's not gonna function correctly. It looks like they got punched in the chest, huh? Yeah,
I
yeah.
wonder if they're like hurt.
Oh, did it hurt, Cody? You remember if it was uncomfortable, or?
Like when I had it, no, I never, I mean, it hurt after I got fixed.
I see if I just get used to it.
How young was I? It started to form, like I didn't always have it. It formed they told me that it formed when I went through my growth spurt. Because I grew really fast, and the explanation that they told me was that because I grew so fast, that my sternum and I guess part of it started to grow inwards because it couldn't keep up with the rest of my body. So it just happened. But it looked like that, but it wasn't as deep. But I mean, it's pretty close.
And like he's saying, from what I used to visualize, it was mostly your adolescents that would have it, when I'm assuming
Yeah,
puberty
they're-
hits.
I got mine like fixed when I was relatively a little older than I should have been. I think I was like 19. I should have got it done when I was like 15.
Oh, so this is kind of like recent.
Huh?
This is kind of recent.
Yeah, I got
yeah.
they put a bar in you when they fixed it.
Yeah.
And
Yeah, this one
it's
uses a
like-
bar, by the way.
Yeah, it's like braces. You keep it for 4 years.
I thought this was when you were like.
So they gotta go get it back out?
Oh, they took it out like I think it was maybe a year before I started here.
Oh, wow.
That taking it out's not painful. Putting it in, I think
Imagine.
it's like a year's worth of pain that I had to sit through. It was very bad.
All right, a few more review questions, guys, and we're gonna wrap it up for the day.
That's me.
So this here, this is my friend Smeagol. This is how you all look taking your exams, by the way. Well, not all of you, but a lot of you look just like this taking your.
Do you watch
exams.
it?
I watch you all the time. Yeah. I like to see what's going through your heads.
You know, I cannot
Crying.
believe one time I fell asleep on your test. And I was like,
oh,
I fell asleep on your test.
All right. Which of the following is classified as a floating rib?
11.
11th rib, very good. The sternocostal joint of the first rib is classified as Sternocostal joints.
Is it A?
That's a trick question.
Oh, there is no.
Well, the
Sternocostal joint.
It is
That's the
not
cartilage
classified
attaching to
as-
the sternum.
It is not classified as a
Okay,
joint.
That's not classified as a
It is
joint.
not classified.
I'm sorry, I wasn't meaning that.
That
one.
was
That was me.
I just wanted to see if you aren't paying attention. So that's not classified as a joint, guys. You can write that down.
Okay.
It's a common mistake. That's just where the cartilage connects to the sternum. That's not actually classified as a joint.
So the
Sternocostal joints.
She's not a joint.
May I ask why you chose this gift to this question?
Cartilage.
Is it soft?
See the fifth.
Every time I see this, I be so upset. I see King.
What's Smiggle?
No, every, like that scene.
Gollum.
Yeah, I was just watching it the other day and I was so mad with Frodo. I was like, Frodo, why don't you
It's
sit
not
in
a
the
joint,
stand?
but it's what's the name of it?
What's the name?
Wait, go back.
Sternocostal joint is not a joint.
It's
It is
just,
not a joint.
what
It's
is
just
it?
where the cartilage is going to connect but where the anterior cartilage connects to the
And the
sternum.
rib connects.
So is it just the sternocostal articulation?
Yes.
Okay, I'm gonna just write that, 'cause this is confusing.
And you may see it written as joint too, by the way, guys, but it's still not technically a joint.
Okay.
Now, as Reagan said, it's most often going to be called the sternocostal articulation. That'd be more the proper name for it. All right, we're going to stop there today, guys, 'cause I am out of time. I am sorry.
Are you?
Yeah, already. I gotta.
I thought you cool.
I know. Did you not hear my announcement?
No.
They have interviews.
Oh, you do?
I
You
have,
know what? I'm gonna peek in
And I'm
there.
also one of my meetings, guys. If y'all remember, I'm going to talk to GE and try to get y'all's room construction. So wish me luck.
Peek in there and be like,
Guys, you do have a break from 9 to 10. Use your time wisely. Whatever y'all like to do, just take a load off, relax, don't get too noisy. Have a class next door. But